This is Yeah, We're Going There with Dr. Natalie, breaking the silence on pelvic health for women and men. Yeah, we're going there because knowledge drives better health. Welcome to Yeah, We're Going There, where we have honest conversations about pelvic health, sex, and topics no one talks about. I'm your host, Dr. Natalie, and today I'm honored to introduce a truly remarkable physician and advocate for women's health, and one of my closest and dearest friends, Dr. Antoanetta Mueller. Dr. Mueller is an OB-gynecologist who has dedicated her career to supporting women through every stage of life, from adolescence to menopause, with a patient-centered approach. She believes women's health is a continuum and that care should evolve alongside each woman's unique needs and experiences. Dr. Mueller completed her medical degree and residency at the University of Miami, Miller School of Medicine, and Jackson Memorial Hospital. Since 2007, she has served the Long Beach community, including leading a 24/7 gynecologic emergency care center and directing Complete Women Care, where she promoted compassionate patient-centered care until opening her private practice in 2021, Beyond Women's Health, where she provides concierge menopause care with a focus on personalized therapy to help patients regain balance and their quality of life. Today, we'll be diving into an incredibly important and timely topic: hormones and menopause. What happens in the body, what women should expect, and how to navigate this stage with confidence and the right support. Let's get started. Hi, Dr. Mueller.
Hi, Natalie.
So my first question for you is, what happens hormonally during perimenopause and menopause?
So during perimenopause, we like to say that the first hormone that is affected is progesterone, because that's the first hormone that the ovaries just don't produce as much of. So you have this estrogen to progesterone imbalance. So essentially, you have an estrogen dominant time period in your life, and the manifestations of a low progesterone are essentially related to mood. So you have worsening PMS, more irritability, more anxiety, poor sleep, and then your cycles also become heavier, sometimes more painful. In menopause, the hormones pretty much stop being produced by the ovaries. Everything shifts to the adrenals. And those are the two glands that sit on top of our kidneys. So when we release our last egg, that is the definition of menopause. We're no longer capable of fertility. And so we don't produce the hormones associated with fertility to sustain the egg. And so we have low estrogen, progesterone, and testosterone across the board.
And how does that manifest?
So that is essentially, for majority of women, not every single woman will have estrogen withdrawal symptoms during that time. And those symptoms include hot flashes and night sweats. The long-term effects, such as osteoporosis and neurodementia and cardiovascular, are not things we feel, right? Those are diagnosed later on in menopause. But the initial onset of menopause is brought on with the symptoms of estrogen withdrawal.
Got it. Okay. And so you explained progesterone, you explained the estrogen, and what do women end up feeling or getting from the reduced testosterone?
So testosterone also just starts declining in your 40s. However, the low libido associated with testosterone is not something that is well researched. Certainly, the FDA has not approved testosterone for management of low libido. A lot of women do feel that they have lower energy, lower libido, inability to put on muscle mass, and they associate it with declining testosterone. That being said, estrogen is actually the first hormone of libido. So you cannot really have improved libido without estrogen. So you have to add back estrogen before you add back testosterone. The other thing is, testosterone therapy is one of those hormones whereby if you're not managing irritability and anxiety, can tend to worsen those symptoms. So it's not the initial hormone that you add back, even though we may all feel the symptoms or the lack of testosterone, you want to add that on at the end after you've balanced the other hormones.
So, how early would you say that hormonal changes typically begin? Like, how early does perimenopause typically
It's a great
present?
question. So something that got me into this sphere like over a decade ago was my personal symptoms of severe PMS and heavy painful periods, and the only treatment was the birth control pill. So we don't know that answer because so many women are on birth control pill in their 30s, mid to late 30s, and in their 40s to suppress symptoms of perimenopause. And so maybe we're going to have a new chapter of data whereby women get off of the birth control pill and try to manage their symptoms in a more holistic way with bioidentical hormones. And then we'll be able to see how early the symptoms start. But I'm guessing they start late 20s, 30s.
So, from what I've read, the average age, and please correct me if I'm wrong, of menopause is about 52 years old, and that perimenopause can begin as early as like 10 years before going into menopause.
Absolutely. But again, if everyone's on a birth control pill, we really don't know. Right. Because the definition of
That's
premature
true.
ovarian failure, yeah, the definition of premature ovarian failure is when your ovaries no longer work and you don't produce an egg and your ovarian function shuts down before the age of 40. It's hard to diagnose that if you're on a birth control pill. So we don't know how many
Right.
women even have that condition. We don't know.
Got you. So, just again, to clarify for all the viewers and listeners, menopause is really just one day. It's the anniversary day of, let's say, being 360 days after your last menstrual cycle. And
Correct.
then afterwards, you're considered postmenopausal.
Yes, exactly.
And so I get it. A lot of women are on birth control. So, what should they be looking for? What could they watch out for that may signal that they are in that
Great questions.
perimenopausal stage?
Personally, I noticed that even on birth control pills, my PMS was still worse. My bleeding was still heavy and very painful. And that's when I said, well, this is not working. I have to pivot. So you're
Got it.
still going to feel worsening symptoms because your body is by far stronger than any synthetic hormone. And eventually it's just not going to it's not going to be able to shut down everything and provide the essential hormones that your body needs to wither that a period of time.
So, what would you say are symptoms of PMS?
So there are two definitions. There's PMS and there's PMDD. So PMS is basically like the week prior to your periods where you have a bloating, mood swings, irritability, anxiety. PMDD is debilitating symptoms that last for 6 months, whereby it's greatly affecting your day to day performance.
Does everybody get PMD?
It's an actual diagnosis now in the DSM 4 of, the psychiatric code, in terms of like the psychiatric book on how to diagnose anxiety, depression. You have to meet certain criteria. PMDD is there. But
So, is
PMS
there,
is a mild form.
right? So, is there a way to differentiate between symptoms of PMS, PMDD, and perimenopause?
Yeah, that's a great question. So PMS again is a mild form whereby the week prior to your periods are just mildly
So, it's a
debilitating.
short period of time, the week prior to your period.
Yeah,
Okay.
but they're not debilitating. They're not affecting your interpersonal relationships. They're not
Okay.
affecting you from performing your day to day function. You're not at home
Does it include like
taking off of
cramping,
work.
back pain?
Well, for sure, yes, but it's the symptoms prior to, because what happens the week before your period is you have this drop in estrogen and mostly progesterone, and it's that progesterone withdrawal that you're feeling, the irritability, the anxiety, you're having horrible bloating, just all of those symptoms. But how severe they are and how debilitating they are qualifies you for the diagnosis of PMDD if it's been for 6 months.
Got it. And then how is perimenopause different than that?
So perimenopause, okay, so imagine like teenagers have hormones like this all over the place. And then you have perimenopause, same hormones all over the place. And in between, you have this like beautiful, smooth reproductive flow, right? So you have those two erratic pulsatile episodes in your life where progesterone's decreasing, testosterone's decreasing, and estrogen's doing this. So you're having withdrawal symptoms, estrogen withdrawal symptoms accompanied by decreasing progesterone. So you're having the irritability, the anxiety, the symptoms of PMS daily,
You have it all.
and you're having estrogen withdrawal symptoms, night sweats, hot flashes. So
Okay.
it's a daily occurrence, not just like the week prior to your period, right?
Okay,
Because
that makes a
PMS,
lot of
yeah,
sense.
because PMS involves a cyclical pattern. But if you're not cyclical and you're perimenopause and your periods are every 1 to 3 months, you compound that by erratic hormone fluctuations. How can I order labs and diagnose anything? It's really tough.
Right. And I do have a question coming up about like blood work and
Hmm.
figuring that out. So I have patients that will come in, and I often feel that they may be coming in for urinary urgency or frequency, maybe pain with intercourse, and they're in their 40s. And I typically ask them, what's your menstrual cycle? And if they tell me it's no longer regular, that it could be super heavy and, doesn't, the days aren't always the same, I start to assume that they're perimenopausal. Is that the right assumption?
Yeah, when your cycles get closer together, it's the decrease in progesterone.
Got it.
Right. And when your cycles get further apart, that means you're not ovulating every month.
So that's the decrease in estrogen. Got you. Okay. And what would you say is like the most overlooked or diagnosed problem associated with menopause, if there is
Menopause or,
one?
or perimenopause?
Let's say menopause.
I think the importance of sleep, because I think without sleep, I don't think we can achieve any of the long term goals my patients want to achieve.
Okay, so I get what you're saying. So patients who are complaining of symptoms, you always address how they're sleeping.
Yeah, if you came off of an international flight and you had no sleep, and you're telling me, I want to lose weight, I have this belly fat that I need to get rid of, I need to have more energy to go to the gym, I'm not nice to my partner or to my family, and you're running on no sleep, how can we tackle any of those
Right. So
if
lack of
you
sleep
don't
really
feel
makes
rested?
everything else worse.
Compounds it just
So no
tenfold.
matter how much you're trying to like fix the hormonal changes, you
Hmm.
also have to address sleep.
Yeah,
And
first.
probably, yeah, okay, got you.
And I don't know what that means for everybody. Everybody needs a different amount of sleep. There's no data to support like you need 8 hours, 7 hours, 6 hours, whatever works for you to feel
Well rested.
somewhat, yeah, rested.
And what about like all the apps that are out now? The Aura
Those are
Ring.
good. Yeah, and I needed that because coming off of a OB and terrible night shifts and waking up with interrupted sleep, I needed to know and to keep myself accountable. That's all it does is it keeps me accountable for going to bed at a certain time every night because whether I go to bed at 8, 9, 10, or 11, I wake up at the exact same hour. My body just wakes up at the same hour every day. So I have to adjust and be accountable for when I fall asleep. And
That
that's
makes
what it
sense.
does.
Okay. And how does menopause affect bone density, heart, weight? I mean, I know, I just want everyone else to know.
Sure. Yeah. So we have estrogen receptors, progesterone, and testosterone receptors on our bones. And so without those hormones, you definitely have the bone loss that starts at the age of 26, right? So at 26, we have decreasing bone mineral density. Now you compound that with no more estrogen, and it's detrimental long term. But the FDA does not approve hormone therapy for the management of osteopenia or osteoporosis, right? You can use hormone therapy for prevention of osteopenia, but it's just not in the literature yet. So it's
So
very
that's a
off label.
shame. Yeah, that's such a shame.
Well, we don't have any studies that show being on hormone therapy for X amount of years and at what dose translates into an improvement in bone mineral density.
We don't. So somebody needs to be doing some research.
Totally off label because the FDA won't approve those
Got you.
clinical trials.
Unfortunately, I hear that a lot with a lot of different medication. And how about heart health? How does it affect heart health?
Fascinating question, which I've been really shocked by. So, the American Heart Association, their website definitely has some incredible literature that states that severity of hot flashes correlates with cardiovascular risk. So, early menopause or premature ovarian failure has the highest mortality risk from cardiovascular events. Everything on their website talks about stopping the spasms of the arteries, which is what a hot flash is, so as to prevent vasospasm, so as to prevent cardiovascular disease. But no one is going to come out and say, therefore, start hormone therapy. But
And
you
what
have to put the two together and
and what about
assume
the
that that's
brain? Because you also mentioned
yeah.
earlier that it helps maintain brain function.
Well, that's another thing we don't have studies on. So we know that there are estrogen receptors on the brain. We know that adding back estrogen helps somewhat with cognitive function.
It's like brain fog.
Yes, but we don't know at we don't have the dosing on
Got it.
that. Because brain fog is also a manifestation of other issues, right? It could be poor sleep, nutrition. We just don't know. That's something, and we don't even know, like, does hormone therapy pass through that blood-brain barrier? How effective is it? We just don't know. So
Got
I
it.
can't dose you with increasing estrogen amounts to get to the brain
Because how
fog.
do you study it?
We
How
don't
do you
know. Yeah.
give it an objective measurement?
And they've looked at MRIs between, looking at postmenopausal women and women of reproductive age, and they haven't really found any difference in terms of brain, like gray matter changes with the lack of estrogen. Our body has adapted to the lack of estrogen in menopause. So it's not like the gray matter decreases or shrinks,
Got
and
it.
that correlates with like dementia. We know that poor diet and high sugar results in inflammation. And we know that Alzheimer's is also considered type 3 diabetes, right? And so that also is part of that spectrum. So it's not just estrogen alone.
And I do know as a physical therapist that without estrogen, we also lose muscle mass. So
Huge.
that will affect weight gain as well, won't it? During menopause.
So estrogen decreasing causes poor
More
insulin sensitivity,
got it. And more
right?
cortisol, I understand.
Well, I think the cortisol increases. Cortisol is the only hormone that increases with age, by far. It's the only hormone that increases with
I didn't
age.
know
We can't
that.
stop it. Yes. So if cortisol is increasing and estrogen
Estro
is decreasing and insulin sensitivity decreases, it's going to be hard for you to lose weight. So the only token of value that you have is muscle, because muscle, when you build muscle, you improve insulin sensitivity
Hmm,
despite decreasing estrogen levels.
got you. Okay. So just because we haven't touched this topic, but it's a biggie, what is hormone replacement therapy for those who
So,
don't know?
yes, hormone replacement therapy is adding back the hormones that your body no longer produces in an individualized manner, not because LabCorp or Quest states that your levels are below the normal range,
Mhm.
because a lot of times you can feel miserable and your range is within normal limits.
So how do
Therefore,
you
it's an
assess
individualist approach.
right, and how do you know? Like, do blood tests work? Because
I do blood test, Natalie, when I see patients who appear to have estrogen dominant symptoms, but also may potentially need to be evaluated for thyroid disease, need to be evaluated for fatigue, because that usually comes as like one of the first symptoms that they present with. So I have to rule
the
out
thyroid.
other
Mhm.
values like ferritin, other inflammatory markers that if your inflammation is through the roof, it's going to be really hard for me to have you feeling better with hormone therapy. So that's what
So
the labs do.
so there's no blood test to measure estrogen.
There is, yeah. So when you measure estrogen, it's the total amount. Estrogen travels bound to a protein. So you're measuring the total amount, not the free estrogen that floats to the cells. The only value that tells me how much testosterone you have free that can go to cells is called free testosterone, and we have that because of men.
Got it.
But there's no free estrogen
Right.
evaluation. There's no.
So assessment is really hard. It's like you have to look at the person from all different angles. And studies I've seen had recommended, well, in the past, as we know, that people were scared of hormone replacement therapy, thinking that it caused breast cancer or blood clots, and doctors were shying away from prescribing it for a long time. And sometimes it's unfortunate, and sometimes for good reason. But is the recommendation still to start within 10 years of going into menopause, and then only for 10 years? Or can you do it indefinitely if you choose to?
I've never, you know me, I did not adhere to those guidelines. So I don't know if they're going to come out and change, because since they pulled that warning off of the estradiol patches and hormone therapy in general, I don't know if they're going to come out with that, because there's no data to support that. So I think starting at the onset of estrogen withdrawal symptoms, whether that's in your 40s, that's great. Why do you have to wait for a certain number? Like, why
And
do you
why
have to wait till
suffer?
you and suffer, right? So we're going to accumulate data that states if you start earlier, then you won't have osteoporosis. You won't have the cognitive decline. You won't have the loss of collagen. You'll you'll have better health span.
So
So why stop?
because there aren't, if there's no data, because for so long no one was using it, right now we're just hoping that it'll all
But yeah,
work and
it's
that
an experiment. Yeah, it's
it's
a
a,
clinical study.
it is.
Yeah, it's a
And
longitudinal experiment.
so I obviously don't prescribe hormone replacement therapy to my patients, but I do pelvic exams and I look at the tissue, the vaginal tissue, and I've learned a tremendous amount. So I didn't mention this in my intro, but Dr. Mueller and I worked together for 4 years. I worked in her practice, seeing patients there, and I learned what I know really from her. But the patients I treat often come in with urinary urgency, urinary frequency, pain, pain with intercourse. And we know that these are often typical signs of genitourinary syndrome of menopause. And when I ask them, "Oh, are you on vaginal estrogen?" And they'll say, "Yeah, I have a patch." And I'm like, "No, no, no, that's not vaginal estrogen. That's hormone replacement therapy." So how do you typically explain the difference to your patients?
Just a side note. So when you were in our practice, what was amazing is I used to do a lot of pelvic floor surgery, a lot of
Right.
like slings, anterior repair for prolapse, just so many. And we used to send all of my post-op patients to you. And then you taught me to implement the pelvic floor therapy prior to surgery when they had symptoms, to see how that would affect. And I think you reduced our surgical load
No,
by
I
like
mean, good
30.
for the patients, not good for the practice.
Patients, actually, not for the practice. Yeah, yeah, I think 30%. Because I remember looking at the numbers with Miriam, and we were like, "Wait a minute, these patients aren't scheduling their surgeries because your pelvic floor therapy was so effective." And I was like, "Darn!" But ultimately, it was the best thing for the patients,
Yes.
and ultimately, it made the surgical results last so much longer. Now, estrogen. So estrogen, even postpartum, is beneficial for healing, and you told me that. And then also, if you notice any kind of dryness, then you need local estrogen. It has nothing to do with the application of estrogen with a patch or a gel to the other thigh or to the abdomen, because you're not going to target the tissue in the vagina. So you need a local application, whether it's testosterone, DHEA, or estrogen. It has to be local.
Right. So this is what I typically tell patients when they say, "Oh, I have the patch." I'll explain that the difference between hormone replacement therapy and vaginal estrogen is that hormone replacement therapy is systemic. It'll work throughout your body, and it's not for everybody. Whereas low dose vaginal estrogen is just that, it's low dose.
Hmm.
And it targets the receptors specifically in the tissue of the vagina. We have estrogen receptors, testosterone receptors down there. And they'll go, well, what about the patch? I'm like, the patch is great, but it's not sufficient to
Correct.
address the vaginal tissue. And I've always kind of felt that every postmenopausal woman should be on vaginal estrogen. I listened to a lecture recently by a urologist who even was talking about women with estrogen positive cancer or
Hmm.
cervical cancer, and that it's such a low dose and that you have
There's
to
no
therefore
systemic
weigh the,
absorption. Yeah.
but patients are still nervous. And she was saying that you could use, like you said, DH, which
Hmm.
is a precursor to both estrogen and testosterone.
Hmm.
Or she was saying you could still use vaginal estrogen, but maybe less of a dose and put it where you need it. So to me, that was very educational and very helpful. But I find like I get a lot of referrals and sometimes from their primary care physicians, sometimes from gynecologists, sometimes from GI doctors. And when I will message them back going, hey, I think this patient would benefit from vaginal estrogen, a lot of them don't know how to prescribe it.
Hmm.
So I find that super interesting. And the other piece is, well, I think that's because of what was going on previously and the black box warning that's no longer there. But it helps maintain a healthy microbiome, the pH levels. It helps reduce the incidence of UTIs.
Hmm.
I mean, women literally go into sepsis from UTIs and die. So, I mean, everything a person puts in their body, there's going to be pros and cons, and you have to weigh it. And again, like you said earlier, it's very individual. But what do you think about like low dose vaginal estrogen for everyone? Does everyone need it? Or will some people never have atrophy or those changes?
Some patients do really well with the patches. It provides enough lubrication at the vaginal level that they don't need an application to that area until probably later on in maybe 60s or so. But if you continue with a systemic estrogen, you may never need a local application. I find that the women who have
Interesting.
the worst atrophy are the women who never had systemic hormone therapy and then are now sexually active or want to have a relationship, and then it's really challenging, and then we have to build up the mucosa.
Got
So
it.
I don't see the level of vaginal atrophy in women who start hormone therapy around 50, which is
That's good to
fascinating.
know.
Yeah.
Yeah, that's interesting. And so going back to the question before where I had mentioned that the guidelines, and I could be wrong, that we're saying starting within 10 years of going to menopause and then stopping. Do you think that people need to stop? Because I have patients
No.
that don't. They're in their 80s and never stopped.
No, and I
A
have
few.
plenty of those. Yeah, I have plenty of those patients and they're incredible. They're day trading, they're hiking. They have the most amazing quality of life in their 80s. And that's how I see myself aging, and I feel every woman is entitled to that. So
I
why
agree.
stop?
I agree, which is, why I'm so vocal about everything. And,
Yeah, and they're able to maintain muscle mass. It's incredible.
with the estrogen.
With the estrogen, yeah, yeah. And at least some of the women that I have in their 70s have amazing muscle mass.
Got it. And
Yeah.
so there's so many things now out on the market. People
Yeah.
are always pushing their wares like prebiotics, probiotics, vaginal probiotics. Do you find that those are worth spending money on?
That's a great question. I used to be bigger on supplements than I am now. And I think a lot of it is because I feel the liver as we get older has been bogged down a lot. And I feel as we get older, we tend to give it more than less. And so I don't want to have any issues whereby I'm adding more stress to the enzymes that are metabolizing my cortisol, all the toxins that I'm eating, and supplements. So the supplements that I do recommend are far fewer than I used to. And probiotics, although they have a definite role, should it be because you just came off of antibiotics and you need to restore your gut flora, I don't think it should be something that you should be doing every single day. I think if you get enough fiber green leafy veggies, low processed foods, avoiding seed oils as much as you can, and sugar, I think you're fine.
Yeah, I think sugar's the big one. So,
Yeah.
can oral probiotics make a difference to the vaginal pH?
Problem with all the probiotics I've studied is we don't know if the cap in the encapsulation withstands the acidity in the stomach and gets all the way to the intestines. We don't know.
So,
We can say that this company has manufactured this capsule. I go to these conferences and there's like 20 vendors trying to pitch their, their products, and we don't know. We honestly don't know. So, and you're looking at a cohort of people who really invest a lot into their health. So they'll say that I see the effects, but they're also eating incredibly well, taking in 30 grams of fiber per day. So we're looking at a total different subset of population.
right. So
And those are
again,
the
it's
people that are taking
super
the probiotics.
individual.
Exactly. So I don't think so. I really think that if you can eat cleaner, I think by far that's amazing. But essentially, the gut lining needs estrogen. And that's huge. Something that people don't understand is that
Yeah, I never heard that.
the lack of estrogen disrupts the gut biome and the flora. And that's why as we get into menopause, you have all these autoimmune conditions because the destruction in the gut lining creates tiny pores or disruptions that allow for the foods that we eat to then enter the bloodstream and then gives us an immune response.
That is super interesting.
Yeah. So that's why
So,
in menopause, you see all these autoimmune conditions, huge amount of inflammation.
so would
It's all linked.
hormone replacement therapy help reduce that?
If you start early enough before the estrogen has completely declined.
So, what
Otherwise, why
age?
do we? So if we can start in our 40s, adding back once we feel the symptoms of estrogen withdrawal, then we shouldn't have any kind of permeability in our gut lining and the development of all these autoimmune conditions that always happen during menopause.
Super interesting. Well, I'm a big believer in hormone replacement therapy. I've been using it since I went into menopause. You're my doctor. And I really believe in it. But is it not for any class of people? Like, kind of, obviously, we know women with previous history of breast cancer, estrogen, positive,
I have those too, Natalie. I
and you
actually
give it
have a
to
lot
them?
of breast cancer. I have a lot of breast cancer survivors that are back on hormone therapy, and they do really, really well because the lack of the hormones allows for their life to just not.
Deteriorate, right.
It's very debilitating for them.
That's
So it's a
interesting.
risk benefit evaluation, and it's very individualized. I do require all my patients to get mammograms every year because if you have an underlying tumor or something suspicious that is estrogen receptor positive, then we do hold off on hormone therapy because
And what if they're
you will
on
be
it, you
getting treatment.
find it, you make them go off?
Yeah, they get off of it, especially if the biopsy shows it's estrogen receptor positive,
Got it.
because the treatment often is to stop estrogen from binding to that tumor and causing proliferation.
And what about vaginal estrogen in those patients? Would you also
They're
hold
fine,
off?
but I think the doctors hold off on everything. I probably wouldn't, but their oncologists do.
Right. So until recently, I feel that fewer doctors check in with the oncologists. But in the past, I've been doing this now for about 12 years. So a lot has changed in 12 years. But in the past, I think doctors were fearful because they didn't know enough, like someone like you who's gotten so much continuing education because they don't teach this in schools, as we know. But in the past, I feel that doctors would say, well, I can't make that decision. Let the oncologist decide. Is it still that way, do you think?
When I first started, I mean, I had all these patients who were seeing a breast surgeon or their oncologist, and it was very black and white. I mean, I don't know what they thought about me. They wouldn't call me or talk to me, but I know that they made it a very hard stop. So there was lack of collaboration.
Yeah.
And I think that's the problem with Western medicine. It's
And
very
fear.
and fear. So it's very fragmented and it's very specialized, but no one communicates to provide the best care for that patient. Well,
So, now I work at Kaiser, and I have to say, that's one thing really truly love about working in that system
mhm,
is that we do collaborate. I mean, it's kind of amazing. That blew me away, and that's the piece I think that I fell in love with in terms of working in that type of setting where it's a multidisciplinary team and everyone is working together with the goal of that one patient. It's been kind of cool. So it's too bad it can't be that way everywhere.
mhm.
Let's say, I guess another question would be, what do you wish every woman knew by age 35? Is there anything?
Looking back, I wish by the age of 35, women were no longer taking birth control pills.
Even though they can get pregnant at 35, many of them.
There are other ways. I think that with precision medicine and these wearables, I think that's huge, but also
A
there
wearable's
are,
a condom?
yeah, and condoms too. But I think we need to come up with different modality to evaluate women's cycles to identify their risk factors earlier on than completely suppressing their ovarian function.
Yeah, no, I agree. I agree. And also,
Like the IUD is wonderful. Like I think the IUD is amazing.
oh yeah, I forgot about IUDs. Right.
Yeah, the intrauterine device I think is amazing. It just provides a local progesterone effect to keep the lining thin, not so much systemic. And
Do
then
you
you could still,
prefer one
yes.
over, like one IUD over the other? Because there's the copper
No,
IUD.
the copper honestly is not for every woman because it can create heavier, more painful periods. But if you are intolerable to hormones, then that works for you, that's great. But what I love about the progesterone releasing IUDs is that you can still manage all the perimenopause symptoms with estrogen without the fear of disrupting the cycle, creating heavier periods.
That is super important for people to
Yes, so
know.
it's my favorite modality of treatment in
Interesting.
perimenopause
And that makes a lot of sense. And
because
I've
right now everyone is getting the same regimen in perimenopause. They're going online and they're just getting the same estrogen patch dose, the same oral progesterone, DHEA. Like I'm seeing this very frequently, and they all have cycles every month, and it's really disruptive
so
because it's an estrogen dominant condition, perimenopause.
right. And then you're giving them more estrogen with the patch.
Yes. The last thing anyone in perimenopause needs is estrogen.
Interesting. Okay. So, but what I've also understood is that to prevent genitourinary syndrome and menopause, low dose vaginal estrogen can be
Perfect.
used
That's okay.
perimenopausally because that doesn't affect the whole
Yeah.
system.
But a lot of these women, Natalie, have underlying fibroids and endometriosis in their
Right.
40s. And the last thing they need is estrogen because those are two estrogen dominant conditions.
And okay, so could you tell everybody what estrogen dominance means?
Estrogen dominance means that, as you get into your 40s and you have less production of progesterone and more estrogen, you have the stimulation of pathology in your uterus that correlates with heavier periods, such as possible fibroids, polyps, or adenomyosis, which is endometriosis within the uterus. And then if you slap on estrogen, you're just going to worsen that. Plus, we're getting a lot of estrogen from the environment, such as xenoestrogens, which are endocrine disruptors, as you know. And that's another contributor to estrogen dominance. Where are we getting progestin from? Nowhere.
And what other symptoms are there of estrogen dominance?
I think the PMS is definitely worse.
Is weight gain one of them?
That's interesting. This is a cute saying that I love to say. So the answer to pollution is dilution. So when you think about the inability to lose weight, your fat cells are holding on for dear life because you have pollutants or toxins in your body. So when someone's having a hard time losing weight, it could just be that they have a lot of inflammation and their body is diluting all of that with fat. That's what fat does. It dilutes the toxins. So that's one of the contributors to inability to lose weight. And those pollutants could be endocrine disruptors.
Got it. So,
So therefore, yes, estrogen dominance could be manifested as that.
and hormone replacement therapy went too soon can exacerbate it.
Well, I mean, okay, so estrogen dominance is also manifested by breast density. And every mammogram I see has dense breast tissue.
And why?
So, because of estrogen dominance, we all in our 40s have way more estrogen to progesterone. Progesterone decreases the proliferation at the level of the breast tissue, estrogen increases it. So, compound that with estrogen patch, birth control pills, or endocrine disruptors, and you have these dense breast tissue findings that decrease identifying pathology on a mammogram by like 15%.
So, what could women do to help reduce estrogen
Progesterone,
dominance?
progesterone.
Okay.
Progesterone, number one, weight loss and watching what they're eating in terms
So,
of what
clean
they're applying
eating.
to their body. Yes, what they're putting on their body, all the bisphosphonates, the plastics, all of those act like estrogen in that they bind to estrogen receptors far longer and stronger than
Got it.
your bioidentical estrogen.
Actually, I don't know if you remember this, but I had estrogen dominance many years ago, and you pointed it out to me. And I did a tremendous amount of research. Basically, everything that you're talking about, cut it. I went through my house, like literally with a magnifying glass. I don't use dryer
Remember
sheets
that?
anymore.
Yeah.
All my makeup, all my creams, soaps, everything. Changed it to clean. And 3 months later, you redid a blood test and you were blown away how my numbers had dropped.
Yeah.
And, just
Because I don't think I was going to start you on estrogen at that time. Or
I th-
there was an issue as to why we were
no,
like
I think
hesitant.
what I remember is that I've always had osteopenia and I wanted a DEXA scan before I started to see if I still have osteopenia. That in my mind was what encouraged me to definitely go on it. And I did. And then I said, okay, I'm ready to start, which I'm super glad I did. Because since then I've learned so much more. So for me, it was the best thing. And the estrogen dominance piece, I think I was holding on to fat also because of it.
Hmm.
So it's all very cool. It's very hard, I think, for a lot of people to wrap their brains around it, who like just the general population. So I think our job is really to make it more simple for
And
people
what's so
to
sad, Natalie, is
understand.
that by the time women finally come in, they're already just like at that spectrum where like, I'm ready to leave my family. I can't tolerate my husband anymore. I'm miserable.
I
And it
know.
doesn't have to get to that.
I
Like
agree.
if we could just tackle symptoms earlier, then we don't have to have this, terrible, terrible presentation.
That's why I'm so big on education. One of the reasons I created this podcast is because I feel that, I find there's a lot of education from one professional to another professional. What I feel is lacking is there's not enough education to the general public. They're all doing
That's a good point.
researching on Google. Some information's great, but it's not all accurate. So evidence-based education, I think, is super important.
As patients, you cannot go to a podcast and assume that this is what you need to be on because this personality told you so, or because your friend is on this regimen, then you should be on this regimen because your friend feels great. No, it's
100%.
so highly individualized. And I think that that's the key. I don't want someone to come into the office saying, my friend's on this regimen and I want to be on it. She looks
Right.
great, feels great.
Right. Well, they have to get that. It's hormone replacement therapy has to be so targeted to the individual, and no two people are alike. And,
Correct. We
what
each
will
have
work
our own
for
set of
one
receptors.
won't work for another. So, yeah, it's trying to get the word out there. Anything that you want to add? Anything I haven't asked you that you
No,
feel we want to let everyone know?
no, I think you tackled everything that That's huge in terms of just information and answering, I think, questions that all my patients
And
have
if
brought to my
people
attention.
and if people want to reach you or get more information, is there a way for them? Can you see patients just to come into your office, or do you do like telehealth? Do they have to be in California? If someone wanted to talk to you about what's going on with them, how would they reach you?
So they could definitely call the office and we could set up an appointment even virtually if you're out of state. Absolutely.
Okay, cool. I will, in the notes of the episode, I will, if that's okay with you, include the office telephone number. So if people have questions, they're able to make an appointment.
Thank you.
This was wonderful. Thank you
It
so
was so much
much.
fun. Yes.
It was great seeing you,
Always.
and I will talk to you soon. Thank you for listening to Yeah, We're Going There with Dr. Natalie. If this conversation helped you feel more informed or less alone, consider subscribing, leaving a review, or sharing the episode. Until next time, yeah, we're going there because knowledge drives better health.